My name is Dr. Hazem. In this video, I will demonstrate a standard ovariohysterectomy procedure performed on a 1-year-old female cat. The objective of this tutorial is to present the surgical steps in a clear, systematic, and reproducible manner. The procedure is performed under general anesthesia and strict aseptic conditions. All steps are shown for educational and training purposes. The procedure begins with preparation of the surgical site. The ventral abdominal area is thoroughly scrubbed using an appropriate antiseptic solution such as povidone iodine. A sterile surgical drape of appropriate size is then placed to maintain an aseptic field. A skin incision measuring approximately 4 to 5 centimeters is made using a scalpel. The incision is positioned approximately 2 finger widths caudal to the umbilicus. This incision length allows adequate exposure while supporting proper healing. Subcutaneous tissues are carefully dissected using blunt and sharp dissection until the muscular layer is clearly visualized. Adequate removal of subcutaneous fat is performed to improve visibility and access. A corresponding incision is then made through the abdominal musculature to enter the peritoneal cavity. A spay hook is introduced into the abdominal cavity. The hook is initially positioned on the far side of the abdomen, facing caudally. The instrument is then gently rotated caudally toward the pelvic region of the animal. Continued rotation brings the hook to face toward the surgeon, allowing engagement of the uterine horn. The hook is then carefully withdrawn to exteriorize the horn. This maneuver may require minor adjustments to achieve successful engagement. Once exteriorized, the uterine horn is examined. In this case, the uterus is partially embedded within adipose tissue. The surrounding fat is carefully dissected to allow proper visualization of the uterine structures. The round ligament supporting the uterine horn is pierced using the spay hook or blunt digital manipulation. Any remaining ligamentous tissue is removed. The suspensory ligament of the ovary is identified. This ligament is located cranially when the uterine horn is positioned correctly. The suspensory ligament is transected. Autoligation of the ovarian vasculature is then performed. This technique provides secure hemostasis and reduces the risk of postoperative hemorrhage. The ovarian vessels are transected distal to the ligature. The ligated pedicle is inspected for bleeding. Once hemostasis is confirmed, the ovarian stump is returned to the abdominal cavity. One uterine horn is now fully secured. The second uterine horn is located using the Spey hook. It typically lies parallel to the first horn. The same steps are repeated for the contralateral ovary and horn with identical technique and precautions. The same steps are repeated, including dissection of surrounding fat, separation and transection of the suspensory ligament, autoligation of the ovarian vasculature, and inspection for hemostasis. Once secured, the ovarian stump is returned to the abdominal cavity. Attention is then directed to the uterine body. Both uterine horns are gently retracted to expose it. A forceps is placed across the uterine body. A suture is passed distal to the forceps and a surgeon's knot is applied, followed by 2 square knots. The procedure is repeated on the opposite side. If necessary, a second ligature may be placed to ensure adequate hemostasis. The uterine body is transected using a scalpel proximal to the forceps. The remaining stump is inspected for bleeding. Once hemostasis is confirmed, it is released into the abdominal cavity. Closure of the abdominal wall is performed using a Ford interlocking suture pattern. A surgeon's knot is placed initially, followed by additional securing knots. The needle is passed from the far side to the near side using an outside-inside, inside-outside pattern. Each loop is passed through the previous loop until the incision is fully closed. The closure is completed with a surgeon's knot and additional square knots. Skin closure may be performed using simple interrupted sutures. In this procedure, an intradermal suture pattern is preferred to minimize external suture visibility. A surgeon's knot is placed at the beginning, followed by intradermal passes along the incision. The closure is completed with a final surgeon's knot. Surgical glue may be applied to the skin incision to provide additional stability and protection. This concludes the ovariohysterectomy procedure. Proper surgical technique, gentle tissue handling, and secure hemostasis are essential for optimal patient outcomes. Thank you for watching.